Neonatal hypertonia. In comparison to hypotonia, hypertonia is less commonly expressed in the neonatal period. The scientific literature on the causes of neonatal hypertonia is scant. Etiologies include conditions affecting the central nervous system and spine, and rare peripheral neuromuscular disorders leading to hypertonia. Etiology onset may be antepartum, peripartum with either transient hypertonia or persistent hypertonia, which may appear later, or from a postnatal event disease. Hypertonia is defined as abnormally increased resistance to externally imposed movement around a joint. It is less common in neonates than hypotonia, and its neuroanatomical site can be central, spinal, or peripheral. Central etiologies may develop antenatally, intrapartum, or postnatally. Clinicians should not assume all neonatal hypertonia is hypoxic ischemic encephalopathy, HIE, or they may miss important conditions with treatments and recurrence risks. Clues to the etiology of and diagnostic approach towards neonatal hypertonia can be gained through careful history and examination of both the neonate and parents. Neonatal hypertonia can manifest as dystonia, spasticity, or rigidity, or a combination thereof. Determining a predominant movement disorder in a neonate can be difficult. Repeated assessment over time helps determine the predominant movement disorder, severity, and affected parts of the body because this changes quickly and markedly in the neonatal period. Data on the incidence of hypertonia and the relative frequencies of the predominant movement disorders and etiologies are lacking. Hypertonia, however, should be distinguished easily from the contractures seen in arthrogryposis. The neuroanatomical site and timing of neonatal hypertonia. Hypertonia can result from central, spinal, or neuromuscular disorders, of which central pathologies are the most common. Central causes may result from developmental abnormalities or injury to the cortex, white matter, and/or basal ganglia and thalami. It is very difficult to determine the neuroanatomical site of injury based on neonatal examination alone. The causes of central hypertonia include those with antenatal onset, such as developmental structural abnormalities to the brain, intrauterine infection, intracerebral hemorrhage or ischemic stroke, perinatal onset, such as ischemic brain injury, and postnatal acquired brain injury. Together, these conditions would fulfill the diagnostic classification of cerebral palsy, CP, if they are non-progressive. The American College of Obstetrician and Gynecologists Task Force on Neonatal Encephalopathy highlights that combinations of distal and proximal risk factors both play a role in the development of CP. Distal factors include genetic abnormalities, for example, COL4A1 gene mutations, or environmental, for example, placental abnormalities or maternal drug use. By definition, progressive causes of central hypertonia, such as mitochondrial disorders, should not be diagnosed as CP, nor should conditions without evidence of brain injury, such as neurotransmitter disorders. The timing of the appearance of neonatal hypertonia may help determine the timing of the development of brain abnormalities, injury, and etiology. Hypotonia typically follows an acute cerebral insult, following which hypertonia develops over the ensuing weeks, months, or years. However, transient increases in tone can be seen sometimes alongside other movement disorders, such as myoclonus or jitteriness, in neonates with hypoxic brain injury receiving hypothermia treatment. This usually resolves. Chronic hypertonia may or may not evolve weeks or months later. Of course, neonatal hypotonia that evolves later into hypertonia is not always HIE, and a careful review of the pregnancy and family history is important in identifying other potential causes. On the other hand, persistent hypertonia from birth is unusual and usually indicative of a distant acquired or developmental abnormality, especially if no encephalopathy, seizure activity, or systemic features are seen. Arthrogryposis, facial abnormalities, or a high arch palate may result in secondary to reduced fetal movements in these cases. A review of the pregnancy, maternal, and family history is mandatory, alongside placental examination. Determining the etiology of neonatal hypertonia. A. Hypertonia obvious from birth. Hypertonia from birth is rare and central in origin. Potential causes include 1. Developmental structural abnormalities or injury to the brain. 2. Meningoencephalitis. 3. Raised intracranial pressure, ICP, for example, caused by congenital tumors, obstructive hydrocephalus or antenatal stroke, and 4 metabolic abnormalities. Antenatal brain injuries are most likely, such as secondary to antenatal hypoxic brain injury, congenital infection, fetal intracranial hemorrhage, such as in neonatal alloimmune thrombocytopenia, or collagen IVA 1 gene mutations, trauma to the fetus, maternal illness, placental umbilical abnormalities, septicemia, cardiac arrest, or drug use. Muscle atrophy, contractures, and dysmorphic features secondary to fetal akinesia may be present if the condition is long-standing. B. Hypertonia appearing acutely, including within the first day after birth. A number of conditions can cause hypertonia relatively quickly within the first few days after birth. The central causes predominate. Etiologies include 1. The transient increase in tone in neonates with HIE, particularly those receiving hypothermia treatment. 2. A predominantly near-total asphyxia close to delivery affecting deep gray matter structures with no or minimal cortical involvement can present with rapid conversion to hypertonia from hypotonia after resuscitation. However, this presents within 3 to 7 days following asphyxia. 3. Brainstem release phenomenon in a child with acute brain injury, often related to hypoxia, extensive perinatal stroke or meningitis, or intracranial hemorrhage. 4. Tonic seizures, which may be secondary from HIE, perinatal stroke, and the neonatal epilepsy syndromes, including Ohtahara syndrome, early myoclonic encephalopathy, EMU, or migrating partial seizures of infancy. 5. Infective etiologies, including meningoencephalitis and cerebral abscess. 6. Intracranial hemorrhage. 7. Raised ICP, such as from extensive perinatal stroke, congenital tumors, or congenital hydrocephalus, which rarely lead to uncali or temporal lobe herniation. 8. Hypereplexia. 9. Metabolic conditions, particularly if associated with a neonatal epilepsy syndrome or stroke. Examples include non-ketotic hyperglycemia, molybdenum cofactor, and serine deficiencies. And 10. The evolution of neonatal hypertonia from an antenatal structural developmental abnormality or injury. Molybdenum cofactor deficiency secondary to a mutation in the MEX1 gene can present with hypertonia, jitteriness, startling, and seizures not classic of HIE and mimic hypereplexia, lactic acidosis, raised cerebrospinal fluid, CSF, lactate, and bilateral infarctions in the middle cerebral artery territories. These clinical findings have been described in hypereplexia. The clue to diagnosis was sulfites and sulfocysteine in the urine with low serum uric acid. Hypereplexia is a relatively benign disorder comprising exaggerated startle response, elicited by the glabellar tap, and hypertonia. Hypereplexia is associated with mutations on chromosome 5 in genes encoding the alpha, 1 subunit of the GLRA, 1 glycine receptor, or in the glycine transporter GLRAT2. Other genetic associations with neonatal hypereplexia are very rare and include ARHGF9, GLRB, GPHN, and SLC6A5 mutations. Treatment is with clonazepam. The hypertonia gradually subsides, and in general, normal development ensues, although persistent hypertonia may be an issue. See neonatal hypertonia persisting beyond a few days of age or of subacute onset. Persistent neonatal hypertonia presenting on the first day after birth or slowly emerging thereafter is a diagnostic puzzle. Although central causes predominate, it is worth asking whether the features are consistent with a central or peripheral disorder at the outset. Central causes. The transient increase in tone seen in neonates with HIE usually settles within a few days. The typical picture of HIE is of hypotonia and encephalopathy early on, with dystonia or spasticity emerging over weeks or months if the basal ganglia, thalami, or cerebral white matter are affected. Therefore, neonates who are born with or become rapidly and persistently hypertonic within the first day after birth do not have HIE, even if encephalopathy is a feature of their illness. Structural abnormalities, such as those caused by developmental abnormalities, stroke, placental pathology, maternal drug use, and congenital infections, are possibilities that should be identified with magnetic resonance imaging, MRI. Maternal medical and pregnancy history and antenatal imaging should be reviewed. The placenta should also be studied where possible. Where congenital infection looks likely, but no viruses are isolated, the congenital-like infections disorders, such as Aicardi-Goutieres syndrome, AGS, should be considered. AGS is a genetic syndrome mimicking congenital viral infections and is associated with intracranial injury and characteristic patterns of intracranial calcification involving the basal ganglia, thalami, and dentate nucleus. Other features include acquired microcephaly, epileptic seizures, poor feeding, eye movement abnormalities, myoclonic jerks, jitteriness, white matter abnormalities, chronic CSF lymphocytosis, and raised CSF interferon alpha, INF alpha. AGS is associated with a number of mutations in several genes, including TREX1, RNASA2A, RNASA2B, RNASA2C, SAMHD1, and ADER1. Spinal trauma during delivery can be associated with a cervical and high thoracic myelopathy or hemorrhage compressing the spinal cord. Preterm infants can have spinal infarctions. The initial features are hypotonia and flaccid paresis, with hypertonia developing later. If the injury is associated with hypoxic brain injury or the need for sedation, these features can easily be missed. Metabolic causes should be considered if other diagnoses have been ruled out. These include 1. Bilirubin encephalopathy, kernicterus, which is rare, 2. Maple syrup urine disease, which leads to dystonic posturing following a period of stupor, poor feeding, vomiting, fluctuating ophthalmoplegia alongside the characteristic urine smell. Although this may not be present in the initial stages, 3. Mitochondrial disorders, such as pyruvate dehydrogenase, PDH deficiency, can present rapid onset hypertonia following a period of hypotonia, irritability, poor suck, along with derangements of liver and renal function, and lactic acidosis. Basal ganglia or thalami injury on MRI can mimic HIE. 4. Serine deficiencies. 5. GTP cyclohydrolase deficiency caused by a novel mutation in the GCH1 gene can present with neonatal hypertonia within a few weeks of birth and responds to L-DOPA. MRI in this condition can show mild paraventricular leukomalacia, which may be confusing. A normal cognitive outcome is possible with treatment. 6 other neurotransmitter defects include secondary deficiencies in mitochondrial DNA depletion syndrome and reduced complex IV activity, CP-apterin reductase deficiency, and autosomal recessive holocarboxylase synthetase deficiency. It may be impossible to find a diagnosis in some neonates. Sometimes the abnormalities can only be found post-mortem, such as dentate olivary dysplasia and olivopontocerebellar atrophy. Other rare central causes include prenatal cocaine exposure, neuroaxonal dystrophy, which is associated with mineralization and widespread neuronal loss in the basal ganglia and thalami, congenital absence of the corticospinal tract seen at postmortem, neuronal loss in the lateral thalami of no known cause, and an unknown syndrome associated with severe growth retardation, microcephaly, obesity, hypogenitalism, and characteristic amphora face size. Peripheral causes. Neonatal tetanus is common in middle and low-income countries because of incomplete maternal vaccination and poor hygiene, such as cutting the umbilical cord with dirty scissors. Maternal vaccination state should be sought. Hypocalcemia and/or hypomagnesemia occur in maternal hyperparathyroidism, leading to neonatal hypertonia tetany, although this is rare, very rare. Myotonia is the sustained contraction of the muscles leading to stiffness, or hypertonia. This can be seen in the autosomal recessive Schwartz-Jampel type 1b syndrome caused by mutations to the HSPG2 gene. Hypertonia can present shortly after birth, but the characteristic facial and skeletal abnormalities will be obvious earlier. Electromyography, EMG, reveals excessive muscle contraction. Unlike in true myotonia, the muscle contraction does not wax and wane and appears as complex repetitive discharges on EMG. The condition, previously called type 2 Schwartz-Jampel syndrome, is now called Stuve-Wiedemann syndrome, caused by mutations in the liver gene on chromosome 5p13, and has similar phenotype to type 1b Schwartz-Jampel syndrome. However, neonates are more frequently hypotonic than hypertonic. Another peripheral cause is neuromyotonia or Isaac's syndrome. This condition usually affects older children and adults in whom it can be acquired, paraneoplastic or hereditary. It is marked by continuous muscle contraction, not stopped by spinal or general anesthetic nor peripheral nerve block. In neonates, congenital Isaac's syndrome may not present until a few weeks of age. The most likely etiology is a mutation in the KCCN01 gene, which codes for a potassium ion channel associated with autosomal dominant hereditary myoclomia. The EMG shows continuous motor unit activity and persists during sleep. Some success has been reported with treatment using phenytoin and carbamazepine. Paramyotonia congenita, caused by mutations in the sodium channel SCN4A gene, can present in the neonatal period with sustained stiffness, recurrent laryngospasm, and stridor. EMG is helpful in making the diagnosis. Treatment options include carbamazepine and mexiletine. The diagnostic approach. 1. When the hypertonia started, which parts of the body are affected, whether it is intermittent or continuous, and the presence of epileptic seizures and degree of consciousness. 2. Family history tree of at least 3 generations to identify A. Learning difficulties, epilepsy, skeletal dysplasia, cataracts, or other illnesses that may represent a genetic or mitochondrial condition. B. Muscle aches and cramps that could be caused by a familial myotonia. C. Porencephaly, anteperinatal intracerebral hemorrhages, or recurrent strokes in children and young adults that may result from a COL4A1 mutation. D. Excessive startle secondary to hyperexplexia, and E. Dystonia resulting from neurotransmitter disorders. 3. Maternal pregnancy history, including A. Prescribed and illicit drug use, B. Sepsis during pregnancy, C. Viral illness during pregnancy, D. Trauma during pregnancy, E. Vaccine status, F. Maternal muscle cramps or aches during pregnancy, which may be a feature of maternal hypoparathyroidism, G. Abnormal fetal movements in liquor volume, suggesting an antenatal onset, H. Cardiotachography results, delivery history, resuscitation, and umbilical cord gases to identify infants with HIE, and I-placental histopathology. An examination of the parents should identify dysmorphia, myotonia, and tetany, the Chvostek sign in mother. The first step in the neonatal evaluation is to determine whether the etiology is central or peripheral. Central causes are suggested by features such as 1. Encephalopathy, 2. Seizures, 3. Meningism, 4. Other organ involvement, for example, liver, enzyme, and clotting abnormalities in HIE, hepatosplenomegaly and petechiae suggestive of congenital cytomegalovirus infection, 5. Micro or macrocephaly, 6. Hyperreflexia including overflow to the contralateral limb and a positive jaw jerk, 7. Signs of raised ICP such as loss of upgaze, a bulging fontanelle, and an increasing head circumference, 8. Hyperalertness and a positive glabellar tap test suggestive of hyperexplexia, and 9. Abnormal ophthalmological findings such as cataracts or retinal abnormalities. Peripheral causes will usually be associated with a normal conscious level and the absence of other organ involvement unless the child has experienced an additional hypoxic insult. Usually, neonatal dysmorphia suggests a genetic condition and therefore a central etiology. Because of the rarity of peripheral causes, this will be the case here too. However, one should be aware of the features of the Schwartz-Jampel syndromes with associated skeletal dysplasia. Similarly, stridor could suggest raised ICP and a central etiology, or the peripheral paramyotonia congenita. Following initial assessment, the investigative approach should be directed by the differential diagnosis rather than a standard list of random tests. In acute and early onset hypertonia, we recommend 1. Treat as meningitis until proven otherwise, if acute onset, 2. Electroencephalography, EEG, 3. Neuroimaging, cranial ultrasound first, and MRI when available, 4. Biochemical investigations including serum calcium, magnesium, lactate, and paired CSF studies, 5. If no other cause is found or the picture is of central origin but with unusual features, Neurotransmitter disorders should be sought on CSF studies. And 6, if clearly hyperexplexia, genetic review testing may be the only investigation required. Neonates with subacute gradual onset central hypertonia should all be investigated with MRI unless the diagnosis is clearly hyperexplexia. If the history and neuroimaging is convincing of hypoxic injury, no further tests are required. Where history, examination, and neuroimaging do not reveal a diagnosis, other central etiologies should be sought. Investigations could include 1. Electroencephalography, 2. Serum lactate, liver and renal function, and clotting studies to identify systemic illness, such as mitochondrial disorders. 3. Cerebrospinal studies for cell count, glucose, lactate, viruses, amino acids, and neurotransmitters. These should be taken with a paired serum sample for glucose, lactate, and amino acids before the lumbar puncture. 4. Muscle and skin biopsy to identify respiratory chain enzyme defects and pyruvate dehydrogenase deficiency. 5. CT if intracranial calcification is possible. 6. Ophthalmological review. And 7. Genetic review. Despite this approach, an etiological basis can be elusive. In these cases, an empirical trial of L-DOPA, starting at 1 mg/kg/d and gradually increasing to 3 to 4 msg/kg/d divided into 2 divided doses, may be worthwhile along with baclofen and benzodiazepines. In cases of tonic seizures, which prove refractory to the standard anti-epilepsy treatment, we recommend a trial of pyridoxal phosphate, 50 mg/kg/d divided into 4 doses, biotin, 5 mg twice a day, and folinic acid, 2.55 mg twice a day. Peripheral etiologies of neonatal hypertonia could be investigated with 1. An EMG in the awakened sleep state to look for myotonia, 2. Serum potassium, calcium, and magnesium, 3. Skeletal survey if a dysplasia is suspected, 4. Genetics review, and 5. Trial of carbamazepine or phenytoin if myotonia is confirmed. Treatment. The treatment depends on the cause, and some treatments can be used as a therapeutic trial during the investigative process. In children with known brain abnormalities, commencing baclofen followed by a benzodiazepine, such as diazepam, is our current first-line treatment. In neonates with refractory seizures, tries vitamins. Where central etiology is expected and no neuro and imaging abnormalities are found, a trial of L-DOPA is warranted following sampling for CSF neurotransmitters. Central hypertonia worsens with pain or distress. Therefore, associated gastroesophageal reflux disease, constipation, or other causes of pain should be addressed simultaneously. In peripheral causes, a trial of carbamazepine followed by phenytoin is warranted. Neonatal hypertonia is caused by a heterogeneous group of disorders. Hypertonia that presents at birth or within the first day after birth is not caused by HIE even if accompanied by encephalopathy, unless the raised tone is secondary to tonic seizures, brainstem release phenomena, or is transient and related to cooling. Subacute onset neonatal hypertonia is most often central in origin, but rare peripheral conditions do exist for which treatments are available.